So thank you for tuning in for today's lecture, which is part of the Women in Surgery Interest Group lecture series. We're happy to have you. My name is Ghina Ghazeeri, Med3 representative, and I'm honored to introduce Dr. Ghazeeri as our guest lecturer. Thank you, Dr. Ghazeeri, and please note that Dr. Ghazeeri even stopped her C-section to be able to do this. So Dr. Ghina Ghazeeri is an associate professor of obstetrics and gynecology. She's a practicing OBGYN at the American University of Beirut Medical Center since 2004. She received her medical degree from the American University of Beirut, where she also completed her OBGYN residency. She did her fellowship in reproductive endocrinology and assisted reproductive technology at the University of Tennessee. She's also received a diploma in clinical embryology from the University of Leeds. Dr. Ghazeeri is a member in multiple scientific and medical societies, such as the American College of Obstetrics and Gynecology and the American Society for Reproductive Medicine. And in case this wasn't enough, Dr. Ghazeeri is also the director of the Fertility Preservation Program. In today's lecture, Dr. Ghazeeri will be tackling OBGYN emergencies, thoroughly going over the most important and common ones. Before we start, kindly make sure your microphones are muted. All throughout the sessions, feel free to type in questions or concerns in the chat box. Thank you. Dr. Ghazeeri, the floor is yours.
Thank you so much, Dan. It's a humbling introduction. I appreciate you inviting me to this platform. And it's my pleasure to be with you tonight on this Friday evening after, I'm sure it's a hectic day for everybody. It will be my pleasure to share with you my experience as a surgeon in OBGYN. And actually, it is not easy to be a woman in surgical specialty. Especially, I don't think it's the problem being in surgical specialty as much as being in the whole OBGYN specialty with all the emergencies that we face during whether our training or whether through our the regular work during every day. It's not being a woman at all, but luckily, and I have been able to pull through up till now. Now, with my presentation today, I'm gonna tackle some surgical emergencies in obstetrics and gynecology, but I will be stopping at some cases that had a significant impact on me during the whole path of my career. And as I was telling one of my residents, these were turning points in my life. Now, other than the fact that I'm a mother and I'm a wife in a surgical specialty, which is not very easy at all, dealing with very sick patients also it's not that easy, with all the psychological toll that it might have on us when we are during our work. I wanted to start with an article that was published today in the New England Journal of Medicine. I received it today. And I think we as a woman in surgery, and with the help of our male colleagues, I think we have to make a change, significant change. This is an article that was published in the New England Journal of Medicine. I received it like 6 hours ago, where a study in the US of medical school graduates from 1979 till 2013, it showed that women were less likely than men to be promoted from assistant to associate professor and from associate to full, and less likely to be appointed department chair. The sex differences have not diminished over time, and I'm sure and I hope that we as women in surgery will be able to make a turn as far as this issue or this problem. So I will be starting with some emergencies that we see in OBGYN, and I'll start with the obstetrical emergencies. As we all know that obstetrical emergencies can be really life-threatening, and they can happen either during pregnancy, during labor, or after delivery. And these emergencies can be either during the first trimester, the second trimester, or the third trimester. The significant first trimester obstetrical emergencies can range from ectopic pregnancy to uterine rupture, mother pregnancy with bleeding, or a miscarriage with bleeding. Third trimester can be previa, accreta, percreta, hypertensive crises, uterine rupture, inversion, and what have you. Now, honestly, over the path of my career, since I graduated from the OBGYN department in 1999, so now you can calculate my age, I have seen most of these complications. And as I said, some of them left an impact on me psychologically, as well as on the progress of my or the path of my career. Now, as we know that ectopic pregnancies can happen, and I'm not going to go into details because I'm sure these things, most of you, they know about, but I would like to shed light into these emergencies and the kind of impact they can have on us and our careers. Now, the acute pregnancy, acute ectopic pregnancy, we know that it happens around 20 in 1,000 pregnancy. I'm sure most of you have seen ruptured ectopic pregnancies. I have seen a lot. Uterine rupture, whether it's spontaneous or without any previous scar in the uterus, or with the previous scar in the uterus. Also, it can range between 1 in 8,000 up to 1 in 1,633. And actually, I have seen the two kinds of rupture during my career, and unfortunately these were during my first few weeks of my residency in OBGYN at the American University of Beirut. Placenta previa, 1 in 2,500. We have seen a lot. Uterine inversion, actually I have never seen a single inversion. We've read about it. And amniotic fluid embolus, I have seen a massive PE in one of my patients. It was traumatizing for me. And unfortunately, the patient did not survive it. And I'm gonna go through I'm gonna go over it along the course of this presentation. Now, we all know that ectopic pregnancy, where the pregnancy can happen anywhere outside the uterine cavity. It can happen in the cervix. It can happen in the tubes. It can happen in the ovaries. It can happen in the abdomen. Recently, I have seen an ectopic pregnancy who came to us from Iraq, where she was 10 weeks pregnant in the cervix after an IVF procedure. And all what I did is I did a trans-cervical KCL injection, as well as an IM methotrexate injection. And the patient did well post-operatively, and we have been following her up with beta-HCG, and really she's doing well. We didn't have to go into surgery because, as you know, that evacuating an ectopic pregnancy from the cervix can have a significant impact on the health of the uterus, and she might end up with a hysterectomy. Now, the ectopic pregnancy diagnosis, we have the triad of abdominal pain, amenorrhea, vaginal bleeding. Some ectopic pregnancies, they happen, they presented with acute chest pain. These were case reports. And the physical examination is very important. Sometimes I can suspect an ectopic pregnancy just from the way the patient calls me over the phone. And the clinical suspicion is extremely important in these cases because these patients might really bleed. Yani, I mean, you might need to go to the operating room even before you do a bedside ultrasound, and you can go down without an ultrasound done by a radiologist. Now, as we all know that to detect an ectopic pregnancy, first you have a high index of suspicion. Sometimes some ectopics they can present to you without you knowing that this patient is pregnant. But being an REI specialist, and we know that with IVF, that these patients they are at high risk of having an ectopic pregnancy. And that's why I have very high index of suspicion, especially that these patients, usually we follow them up with the beta HCG, and we know that a value that's not increasing by 60%, these patients might be at definitely at high risk of an ectopic pregnancy or miscarriage. Now, in case of a suspected rupture, definitely the best kind of treatment is an emergency laparoscopy. Laparotomy, this is if you don't have the setup for a laparoscopy. And when you are doing the laparoscopy, you have to make sure that you have a large bore suction tubing because you have to expect a significant amount of blood inside the pelvis. Now, as I said earlier, the ectopic pregnancy can happen anywhere between the cervix, the tubes, the ovary, anywhere in the tubes, even in the cornual end. I have seen 2 patients with cornual pregnancies. The first one, she had a heterotopic cornual pregnancy and intrauterine. I was at that time in Memphis. We did a KCL injection of the cornual pregnancy. The intrauterine pregnancy survived, and the patient delivered at 36 weeks. And the latest cornual pregnancy I have seen was a patient at AUB where I had to go and do a surgical excision of this cornual pregnancy. And you can imagine that we did remove part of the cornual end, and we compromised the size of the uterus. But this is when the patient was impending rupture. She was in severe pain. I mean, we didn't have time to do the transvaginal KCL injection of the cornual or transabdominal injection of the KCL for treating the cornual pregnancy. Now, uterine rupture. Uterine rupture is one of the feared complications and one of the serious emergencies that we see in our specialty in the OBGYN. And as you can read that the uterine rupture can be diagnosed doing an ultrasound. However, اقرأ تفرح جرب تحزن, يعني it's not easy to get the ultrasound immediately and then do the ultrasound and do a bedside ultrasound, because this is a real surgical emergency and you should have a very high index of suspicion. I can remember 3 uterine ruptures that I have seen in my career. As I said, the first 2 were during my residency. Actually, the first one was a patient who had a previous C-section for a breech. And I was just talking to her. It was like 2 a.m. in the morning. I admitted her. I was just taking regular history from her. And I was looking, she was in active labor. I was looking at the monitor and suddenly the fetal heart dropped to 50. I did a pelvic I did a pelvic exam and I lost the presenting part. I was the one who examined her at the beginning and I lost the presenting part. I couldn't palpate the head. And this is when I called the resident. I told him I have a uterine rupture. He thought I was kidding. And she was rushed to the OR, but unfortunately the baby had a cerebral palsy. This was before the C-section room was in the same setup as the labor and delivery. Now we can get the baby out in maybe like 3 minutes. So hopefully the patient, the mother and the baby should be fine. The second uterine rupture that I can remember is a patient who had a spontaneous rupture. She was a cytotech induction and we were going by protocol. But she didn't volunteer any kind of surgical procedure before to her uterus. And it was exactly the same presentation where you lose the presenting part. So it can be dull aching pain in the lower abdomen, and it's followed by a sensation of giving away and reduced with the pain disappears. And she says that I don't have pain anymore, no contractions anymore. And in case of complete scar rupture, the fetus comes outside the uterus. This is what happened with the first case. And the fetal parts might become more superficially palpable when you are doing your abdominal exam. Now, the third patient that I remember very well, she was a patient who had a previous uterine perforation after a hysteroscopy. And they did lots of cautery. This is what she described. And she did IVF procedure in Colombia. She got pregnant, and then she had uterine rupture at 32 weeks, but unfortunately, her baby did not make it. And then when she came to me, I did IVF procedure for her with embryo transfer. She got pregnant, and unfortunately, she had the rupture at 27 weeks. I remember when she was in a hotel, I rushed to her hotel. I picked her up and I got her to the labor and delivery, and I delivered her because I had the high index of suspicion that she might be having a uterine rupture. Unfortunately, she ended with a hysterectomy, and the second pregnancy, she had to use surrogate uterus to get pregnant. Now, as I said earlier, we can have either complete or we can have an incomplete rupture, where complete, the whole scar is exposed. It is you lose the whole uterine scar. And incomplete, this is when we have dehiscence, where we still have a cover of peritoneum over the uterine incision. And this is definitely it has much better outcome than the complete uterine rupture. Now here you can see that the fetal parts are getting outside the uterine scar, and you can palpate the fetal parts through the abdominal examination if you have time to do the ultrasound and you are not facing a significant fetal distress at this point. Now, the outcome most of the time, the patients might end up with a hysterectomy because either of severe bleeding or DIC. We try to salvage the uterus, but as I said, it has been, the last patient, we were not able to salvage the uterus. It was a complete mess. She was bleeding, and we had to save her life by removing her uterus. Now, another surgical emergency that we see in our career, which is the placenta, which abnormal placentation, like the placenta accreta, percreta, or increta, or placenta previa, or vasa previa. And as we all know that it is because of an abnormal placentation where the placenta is implanted in an abnormal place instead other than the fundus. And accreta, usually the predisposing factors should be a previous uterine scar, like a C-section scar or a DNC or intrauterine adhesions or uterine perforation. And this is where the placenta can invade in an abnormal place and get stuck to the uterine wall. These kind of emergencies also that usually we have to be prepared for. Now with the advent of an ultrasound, you can see these lacunae and vascularization at the previous scar, and you will have high index of suspicion of a placenta accreta. And the next step would be doing an MRI, because these cases, they have to be planned, where I advise not to have only a single surgeon during the operation. You might need to have a urologist with you on board. You might need to have the anesthesia have to be also on board. The blood bank has to be ready. And a radiologist might be also on board to proceed with the process of with embolization if you need to go for any kind of embolization. Now, accretas can be either mild accreta, where just it is adherent to the previous scar, increta, or it might be just invading the uterine cavity, and percreta. This is when it is reaching the bladder or other organs, and we all know that the placenta is highly vascular, and this would increase the risk of bleeding and hemorrhagic shock in these patients. Now, another OB emergency that, yes? You can hear me?
Yes, we can hear you.
Okay, now, another emergency that you might be facing as an obstetrical emergency might be the placenta previa, and definitely I have seen a lot of placenta previas during my career. But as I said, these cases you should be able to diagnose them ahead of time, because you will be ready with the blood bank on board and the radiologist on board in case you might need to go for any kind of embolization. Most of the cases of placenta previa that I went we were able to control the bleeding by using just the Bakri balloon. And most of the patients that we did placenta previa surgery for them, we were able to save their uteri. Now, the different kinds of placenta previa that we can have the normal placenta implantation. This is not placenta previa. It can be marginal, partial, or total placenta previa, where it's covering the whole cervical os. In case of partial and marginal previa, most of the time the placenta will migrate and the patient might end up with a normal vaginal delivery. But we have to be very careful if there is a marginal previa around term, because once the cervix dilates, the patient might start bleeding, and this is when you have to be ready for an emergency delivery or an emergency C-section. Now, this is one also of the significant emergencies that we fear from, and this is called the vasa previa. This is when the veins, the placenta vessels pass through the amniotic membranes, and if the patient ruptures her membranes, the fetal vessels will bleed, and the baby might succumb to severe hemorrhage and bleeding. And this is definitely an emergency where you should have a double setup. It's very difficult to diagnose it through an ultrasound. And the most important criteria here is to have very high index of suspicion in case of fresh vaginal bleeding in patients who you don't have a history on for placenta previa, or you don't have any risk factors for placental abruption. So you are left with the only diagnosis of placenta previa as the cause of the fetal distress and the active vaginal bleeding during labor or after rupture of membranes. Now, this is another emergency, obstetrical emergency, that actually luckily I have never seen before, but we hear about it, we read about it, and usually we get ready in case the placenta takes a long time to be delivered. Usually this is uterine inversion. This is when the placenta fails to detach from the uterus as it exits, and it pulls on the inside surface of the uterus to the outside. The patient will have heavy bleeding, and she will be in shock. She will lose lots of blood. She will be hypotensive. Diagnosing it's just by having a high index of suspicion. It's not very difficult to miss the diagnosis in these cases. And you have to return the uterus to the original location. It can be either first degree or second degree or third degree, and this is when the fundus of the uterus is getting to the outside. The patient will not be hemodynamically stable at this point. Now, the amniotic fluid embolus, it is one of the most fearful emergencies that you can have. And you have to be able to differentiate between an amniotic fluid embolus and a pulmonary embolus. Usually it is when the patient deteriorates beyond what you can explain according to her medical condition. And the latest pulmonary embolus that I can remember, it's a patient whom I was doing a C-section on, and I was talking to her. I was just suturing. I was talking to her, asking her what she's gonna name the baby, and suddenly she was saying, "I can't breathe. I can't breathe anymore." And then this is when her saturation started dropping. This was after I delivered her. She had a C-section for failure of progress. And I had a high index of suspicion for a PE on this patient, because I was like 6 months over a patient who had a massive PE, and she passed away because of that massive PE. And luckily, we were able to save Anita's life. We were quick. We had a bedside echocardiography. We saw the right heart strain. We took ABGs. We resuscitated her she was intubated immediately, and then she was taken to the RCU with enough anticoagulation, and luckily she did really well. She was extubated the second day, and the second baby she did well with the proper medication. Now, as I told you earlier, I have few incidents during my career that I think I will never forget them. And every time I think about it, it's not because I feel that we have done something wrong. It's just because you have seen a life in front of you suffering, severe suffering, and sometimes you might not be able to do anything. And I remember this patient that I had. Her name, she was Abir, and she had a miscarriage at 16 weeks. And I terminated her pregnancy with cytotec. It took like 18 hours of admission in the labor and delivery. And then after 16 hours of Pitocin and cytotec, the patient was able to expel the fetus with the placenta. And exactly 4 hours later, when I removed the fetus and removed the placenta, 16 weeks, there is a fully formed placenta. I did an ultrasound and I made sure that her uterine cavity was fine. I didn't use any kind of DNC on her. And then she was ready to go home, and suddenly she was coded. At this point, I was with her when she was coded, because I was passing by. I just had the delivery and they were coding her, and I rushed to she was in the bathroom, on the floor of the bathroom. She was gasping for a breath. I resuscitated her, and she was intubated immediately. We did CPR on the floor, and then CPR on the bed. We didn't know what was going on. We thought that she was having a hemorrhagic shock. And then we did a bedside ultrasound when we had significant right heart strain. We took some blood tests, and definitely it was a massive saddle PE. And the patient was taken to the ICU, and she had a stormy course later on. These are one of the cases that I can never forget in my life. Now, going back to the amniotic fluid embolus, which is as bad, even worse than a regular embolus. It can cause sudden shortness of breath, as I said, with excess fluid in the lungs, sudden low blood pressures. The patient will be hypotensive, sudden circulatory failure. She will have an alerted mental status. Usually it comes after rupturing the membranes, seizure, coma, fetal distress, and it needs immediate delivery. I have never seen an amniotic fluid embolus, luckily, but I have heard about it with one of my colleagues. Now, definitely diagnosis is important, but as I said earlier, you should have a very high index of suspicion to get a diagnosis of amniotic fluid embolus, and definitely the fetus has to be delivered immediately. Now, the treatment is to maintain a good systolic blood pressure with lots of fluid, a good urine output, 25 cc's per hour. You have to establish uterine tone. Usually, these patients go into an active DIC. We have to correct the coagulation abnormalities, administer oxygen. Many times, these patients are intubate as if necessary, and initiate CPR also in case this is necessary. I'm sorry. Now, another obstetrical emergency that we might face as an OBGYN is the cord prolapse. And we have 3 clinical types of abnormal descent of the umbilical cord. One of them is cord presentation. This is when you do an ultrasound and finally you get surprised with the whole loop of cord as a presenting part instead of the head or the buttock. Occult prolapse of the cord. Sorry. Occult prolapse of the cord also is another emergency, and total cord prolapse is the third form of abnormal descent of the cord. I remember the three different types: so the cord presentation, or occult prolapse, or cord prolapse, total cord prolapse, and definitely the emergency C-section being very active in the management. The baby will be fine, and the mother also will be fine too. One of the emergencies that I can remember and I can share with you is a patient who had an occult prolapse of the cord during delivery. I mean, during the second stage of labor. Usually the cord prolapse is when the patient is laboring and she has sudden rupture of membranes, and the cord is with grand multiparous, or if she has a polyhydramnios, the cord will slip and it will come out. But this patient, we were transferring her to the delivery room. She was S+2, and I got surprised just with the cord in front of the baby's head, and you can imagine the state of emergency that we had. I had to put a vacuum to get the baby out because he was already S+2, and she was fully epiduralized, and luckily both the mother and the baby were fine. Now, I think I'm done with many of our obstetrical emergencies, and I shared some of my experiences, or shared my experience with you over the past few years. And I'll come to the gynecological emergencies. Now, the gynecological emergencies in our specialty are not that much. They don't put a stress on us as surgeons as much as the obstetrical emergencies, for a very simple reason. With obstetrical emergencies, you are caring for two lives, and you think about saving both at the same time. Now, as far as the gynecological emergencies, these are disease conditions of the female reproductive system that threaten the life of the woman, her sexual function, and the perpetuation of her fertility. Now, I will list some of them here. Some of them, like the twisted or ruptured ovarian cyst, ovarian torsion of subserous fibroids, non-pregnancy related heavy vaginal bleeding with anovulation, that we can see patients really heavily bleeding. Patients presenting with an acute PID where the patient might be in septic shock, where she doesn't respond to resuscitation and to antibiotics, and you have to operate to remove the source of infection, whether it's a uterus or a tube or a tubo-ovarian abscess, as well as complicated ovarian cysts with bleeding or with rupture. Now, with a twisted or a torsed ovarian cyst, as I said, with ectopic pregnancy, you should have a very high index of suspicion, because usually the presentation of the patient's presentation is beyond what you can explain with your physical findings. I still remember patients with ovarian torsion calling me, screaming over the phone, or doubling over to the emergency room where she cannot move, and her presentation is much worse than her physical findings on her physical examination, where you might find a semi-soft abdomen. And when you do the ultrasound, you cannot explain her presentation with what you see on the ultrasound. Now, with the advent of the ultrasound, you can have a high index of suspicion for torsion, but it is not very diagnostic. The high index of suspicion is when you see that the whole adnexa is moved or shifted to a different place than its normal location. And sometimes you can diagnose edematous ovary with shifting or pushing of the follicles to the extremity or to the periphery of the ovary when you have an ovarian torsion in mind, when you are trying to diagnose an ovarian torsion. This is a picture where you can see that with the ovarian torsion, you will have a compromise of the blood supply to the ovary. And as we have been taught during our medical school years, when there is a decreased blood supply, where there is a vascular compromise to any organ, it can cause pain beyond what you can explain by physical findings. And that's what will explain the pain with a twisted ovary or with ovarian torsion. Torsion also can happen in myomas if they are subserous myomas. And also the patients will present with severe pain. And as you all know, that a decreased blood supply to the myoma can result in what we call something like degeneration. And degeneration can be really painful, and it might need a surgical intervention at this point. Now, very quickly, we know that the fibroids can exist in different locations. It can be intramural, submucosal, subserosal. There are other locations where you can find fibroids in the broad ligament, in the cervix. And these fibroids can either torse or twist if they are subserous, or they can undergo degeneration with severe pain. And this is when your clinical sense might play a very big role, where patients might be presenting with severe abdominal pain. If you find an intramural fibroid with degeneration, just pain control with no surgery can be the solution. Where in case of a subserosal fibroid, you might need to operate on these patients if it is a pedunculated and twisted subserosal fibroid. Now, the emergencies, the gynecological emergencies that you can face in your in the OBGYN field, and that might need a surgical intervention, is the abnormal uterine bleeding. And we have to be very careful in evaluating the amount of bleeding in these cases, and whether this is obstetrical or non-obstetrical. And definitely it is the clinical presentation that might play the most important role in these cases, where sometimes we have the tendency to wait, but we have to be very careful not to wait enough to reach a stage of DIC. And this is when you have to be careful about the surgical intervention and what time you have to intervene in these cases. Definitely, as you all know, we have to resuscitate the patients with enough fluid, blood products. Some patients might not agree to go into a DNC because we know that the DNC might increase the risk of intrauterine adhesions. And they might elect to go for some kind of a radiological procedure. Also, radiological procedures can have their own negative implications, where they might increase the risk at one point if they are not done in good hands, or depending on the indications, they might increase the risk of ovarian failure, premature ovarian insufficiency. And that's why we have to be very careful at this point about the when to intervene radiologically in these cases. In cases of vaginal bleeding, as we all know, medical management has to be number one option for us, and then it has to be followed by the surgical treatment if we are not able to do the medical treatment is not helpful. I'm not going to go into the details of the medical treatment. Now, acute pelvic inflammatory disease can be a surgical emergency, and this is when the patient might be in septic shock and she's not responding to fluid resuscitation. And this is, I can remember one of my patients where she had PID, she received the first 6 hours IV antibiotics, resuscitation, and then in the ICU, she was not doing well. She was going into almost an ARDS because of the significant inflammation that she had. And we knew that she had a tube ovarian abscess. We had to intervene surgically. remove the tube ovarian abscess, clean the PID, and then patients do well most of the time once you remove the source of infection. So as I was trying to show you during the presentation, the most important thing is the clinical presentation, having a very good clinical sense, a very good support system around you, and intervening at the right moment, at the right time in these cases. Now, the other surgical emergencies, as far as torsion and ovarian cysts, coming back to them, as I said before, you can have a ovarian abscess that might not end up well with medications, torsion of the ovarian cyst, ruptured ovarian cyst, ruptured hemorrhagic cyst. We have seen patients losing like at least 1.5 or 2 liters of blood just because of a ruptured ovarian cyst, and we have to go into the operating room, do a laparoscopy, evacuate the bleeding, evacuate the blood, and try to control the bleeding. However, depends on the patient status. Stable patients, you can afford to wait and see. Sometimes you might transfuse. However, my experience in these patients don't leave a good amount of blood in the pelvis. This blood has to be out because the patient will have significant complaints from this blood in the pelvis, whether it's a GI, fever, ileus. This blood has to be cleared in these cases. I think I came to the end of my my presentation, where I think I covered the ovarian cysts, whether they are complicated, the ovarian abscesses, where you can go into these treating these cysts as a case of emergency. And I think I'll open the floor to any questions. If anybody have any questions, I'll be glad to answer any question that you do have.
Thank you, Dr. Ghazeeri, for the very informative lecture. It was an absolute pleasure having you with us. Thank you, everyone, for joining us today. We will be now taking questions. There are already 2 questions, Dr. Ghazeeri. So the first one says, upon detection of placenta accreta, increta, percreta on ultrasound, how often would you personally recommend elective hysterectomy, and how often is the uterus salvageable in such cases?
Okay. Now, I believe when you diagnose placenta accreta, increta, or percreta, accreta, it is not often that you go into a hysterectomy in these cases, because you can tamponade the bleeding, whether with sutures, whether with radiological treatment, or whether balloon. This is, I'm saying accreta. Now, in case of increta or percreta, there is very high chance that the patient might end up with a hysterectomy. And I believe here plays the role of counseling the patients, where you can sit down with the patient and counsel her extensively about what she will be facing, whether during or after the procedure. Because you don't want to leave parts of the placenta inside in case of placenta accreta or increta. And then there are certain reports where doctors have used methotrexate in these patients, and this will increase the risk of DIC and pelvic infection, and she might still end up with a hysterectomy. Now, I think it's a joint choice between the patient and her physician. And it depends on the severity of the accreta or the percreta. Like, I think we have a case now in hospitalized, where we know that the placenta might be invading even the iliac vessels. And this is definitely a patient who will not end up with a regular delivery, C-section. This patient will end up with a hysterectomy. And she has to understand that she might really bleed a lot, and she will receive lots of transfusions at this point because of the involvement of her iliac vessels. So it is the amount of the invasion or the severity of the accreta that the patient have, and the communication between the patient and her physician, and the proper counseling about the upcoming procedure.
Great, thank you. Second question is, with regards to a cervical ectopic pregnancy, Why might surgical excision result in a hysterectomy, as you mentioned?
Yes, because with a surgical, how are you going to reach it? Are you going to reach it abdominal or are you going to reach it cervical? And when you are going to reach it cervical, the patient might bleed a lot because it is a pregnancy. And you have to be ready with the balloons and whether a Foley balloon or a battery balloon to tamponade the bleeding. So it's easier said than done. I have seen patients bleeding for when we were trying to evacuate her cervical ectopic, and you have to be really sure about your diagnosis, because some patients might have an aborting pregnancy that's stuck in the cervical canal. This is not a cervical ectopic. A cervical ectopic is an ectopic that's invading the cervical tissue. And this is where I find that it's a multidisciplinary approach where you can have both the high-risk doctors and the regular OBGYN performing the procedure. As I said, I have done many with a transcervical injection of KCL, and then I am methotrexate. It is exactly like you manage an ectopic in the C-section scar. It's not easy, but maybe surgical evacuation might be easier in the C-section scar, but some patients might elect to go for the medical and conservative treatment, which might take really a longer time to recover.
Thank you. We have a few general questions as well. So,
go ahead.
If crisis occurs, do you find yourself freezing up with what happens, or do you eventually get used to the feeling?
I can't say that I get used to the feeling, but now, with experience, it's not getting used as much as you are experienced enough to know what to expect. Okay. And to be honest with you, I never shy away from asking for help, because at this point, it is your patient's life in your hands, and everybody has to be around you, has to be with you to help in saving her life. Like in cases of Akrita, if I see that I need another hand with me, there is no problem about it. Okay. I have done Akritas and ectopics as much as you want, but I feel confident enough to do them alone, and confident enough to ask for help if I need any help. Okay. So the most important, I can't say that I don't freeze. Okay. But definitely this bitter feeling, like, you remember when I told you this patient who coded in front of my eyes? It is a devastating feeling. This patient, I delivered her with three kids before. So definitely I need help with me, because I didn't know if this was surgical, if it was an embolus, because at the moment you don't know what's going on. You have to put like 100 differential diagnoses in your head to reach the proper diagnosis. Okay. So the most important thing is to freeze your nerves, to be under control. I can't say that I must not be tachycardic. I became tachycardic many times, but it has a beautiful feeling when you do really well and you save both lives, really.
Okay, so another question. Can you give us an advice for females who want to enter this specialty? And a lot of people frustrate us.
Oh my God, I was waiting for this question. Okay. You remember the article that I shared with you at the beginning of my presentation, where unfortunately this was published in the New England Journal of Medicine, I think maybe today or a few days ago, where women are not giving enough as far as what they deserve to be in positions or to be promoted from assistant to associate to professor, or even leading places in as chairperson. I think women can do magic and they can do a lot. Okay. But honestly, I believe in the social fabric and the social support around us, which can help us do a lot. We are excellent communicators. We are very creative. We are very enthusiastic, and we are very empathetic. We are caring, and women can be in big surgical positions, I believe. However, the woman, by the end of the day, if she's a mother or a wife, will still want to play the good. I'm not saying the perfect, because nobody is perfect. I thought that I have to be perfect, but then I changed. She wants to play a good role for her family, and whether she has kids or she has a husband or she has a family to take care of. And we are multitaskers, and we have to know what to expect, and we have to put ourselves in the mindset that we are doing the best that we can. I would really, I need to thank my family, because really they were really understanding over all the past years for what I passed through in my career. There are certain points where I feel, I don't know if I could have done a different thing, where honestly I passed through a lot, and I had a big support from my family, my husband, my parents, my mother. My mother took care of my kids in an amazing way. She helped me raising my kids. She helped me take care of my household. You need help. You cannot say that I can do it all by myself. I can be the best surgeon, the best mother, and I can take the best care of my house. You need some help, and you have at one point to accept that the job might not be the perfect job, but this is the best that you can do. And I'm sure that you can do, every woman can do an amazing job. But as I said, you need some support around you, and people around you have to understand that they are helping you because you are working for a bigger cause. I hope I answered your questions.
Absolutely. Thank you, Dr. Ghazeeri. There's just one more, but I think you covered it by saying this. And it says, are emergencies as frequent as you said it would be, or is lifestyle more or less not stressful? I think you covered that, but
yeah, I think so.
Yeah. Okay.
You know, I need to end my presentation with a funny incident that happened when my kids were still very young. And you know, in Lebanon, patients keep calling you all the time. I mean, there is no privacy as far as your private telephone is concerned, where they believe that they can reach you day and night. And I was so enthusiastic when I came back from the States. I was giving my telephone to everybody. I was helpful to everybody. And definitely I had 3 kids to care for because my husband was traveling. And I would say that my phone used to ring at least 3 times in an hour. And you know that when I come back home, I have to take care of feeding my children, helping them with their studies. And till one time when I went for a parent-teacher meeting for my youngest daughter, and they showed me a picture where they asked her to draw your mother. She drew me wearing my gown and at home. She said, this is mom at home. So this is the doctor mom at home. And I was holding a telephone with my hand. And this is when I decided to, it was funny for them. It was not funny for me, because this is the only thing that my daughter remembers about me, just talking over the phone with my patients. So this is when I decided, you have to be smart enough to differentiate between time for your work, time for your job, and time for your family. And I think with some lean management where you can manage your patient's expectations, you can do the good job with both your patients and with your family. I decided to put my telephone silent, answer my phone calls at night when my kids are asleep, and in case of emergency, patient can call the delivery suite or the emergency room for any emergency, because there is some sacred time that you have to save for your family.
Thank you, Dr. Ghazeeri. Honestly, it was a very inspiring session, and we cannot but thank you for that. So thanks
You're
again.
welcome.
And thank you everyone for tuning in. This was Jan Ghanem, Met3 representative, and we'll see you during the next session.
Thank you. Thank you, everybody, and have a lovely weekend.